I have never had a patient, not once, not ever, come into my room and tell me they want to die more cost effectively. Not once. And yet, we know that the whole idea of survivorship is not just how do you survive your cancer, but when you're not going to survive your cancer, how do you live the remainder of your life? You know, so I put a bigger circle around survivorship. And you know, as we move away from try every last thing to live every last moment, and we get into precision medicine, one of the benefits of precision medicine is to know when to stop sooner. And then the other benefit is that there are things you can do as time goes on where you can prevent second cancers and recurrences and things. So this whole concept of survivorship, do you both believe that the current models have spent enough time thinking about survivorship and end-of-life care? Because I kind of put those two things together. Or do you think there's more room for improvement?
Yeah, I think the current alternative payment models largely focus in oncology on patients on active treatment. So that would exclude a large portion of those patients in terms of just long-term survivorship clinic. And that would leave just those patients with towards the end of life in your survivorship model. I really like what you said about precision medicine, and kind of to take that and analogize it would be, for really successful survivorship, we need to do precision goals of care. So that N of 1, that patient, what do they specifically exactly want out of their care? They don't say, I want the most cost-effective care, but they might have strong feelings about, I don't want to die intubated on a ventilator, or I don't want to spend my last 30 days at a hospital 2 hours from my family, or a feeding tube, or these other things. And so having those discussions take time, they're difficult, and they change week to week, month to month, but having a process in place for that, I think will be really important to, you might want to say cost-effective care, but from the patient's eyes, it's having kind of the most effective care for their goals.
Right.
So I agree. I think that survivorship planning and hospice planning are incredibly important. Right now, the focus really is on trying to reduce the variability in what is provided to patients who are, as you mentioned, on active treatment. But we're already seeing providers start to talk a lot more about end-of-life care within this. And I wouldn't be surprised if the kind of alternative payment model 2.0 or 3.0 that we ultimately get in a couple of years has a much greater emphasis either in terms of standalone payments for end-of-life care planning and survivorship planning, or quality metrics attached to those, or both, that really, again, puts the patient at the center of both their treatment but also their survivorship. One last thing that I think is really important here is that it's not just putting patients at the center of the long-term consequences of their treatment, but also there are financial issues related to their long-term implications of their treatment that I think we're beginning to see more data about, and physicians and insurers be more cognizant of. The more that patients are at risk for taking responsibility for their cancer care, the more they have to come up with money to pay for stem cell transplants and other types of things that their insurers may not pay the full price of. So thinking about care planning, that's not just about long-term patient outcomes, but also the financial consequences of patients for surviving their cancer but now having really big medical bills that they have to deal with I think is the future.
So this has been a really great discussion. Let's take a minute to get Dr. Sagar to jump in and give us her perspective.
So do I think that APMs account for survivorship care? Absolutely. Our model does talk about emphasis on survivorship care. Couple of key components here is we want the treating oncologist to tie back to the patient's primary care physician, if there is one. For some patients, we do understand that the oncologist becomes a primary care physician, at least for that duration that they're taking care of them, especially in advanced stage illnesses. But we feel that a lot of times primary care physicians have had a relationship with that patient for a lot longer than the oncologist has. And they may have a relationship with the whole family a lot of times. So the oncologist has to tie it back to the primary care physician, and we're hoping that they will give them a summary of what treatment did the patient have, what kind of diagnosis did they have, what stage of cancer, what can they expect, and what are the treatments or surveillance strategies that need to be incorporated. Do they need to have scans on a regular basis, and who will be in charge of ordering those scans? So those are all key questions that need to be incorporated in, and our model definitely does that.